All right. So I don't know if you guys can hear me. So good evening, good morning, good afternoon, depending where you are, where you're following us, where you are receiving this video. Good evening from Facebook, from YouTube, from any other platform that you're using right now to listen to us. We welcome you to our show tonight. I am your host. My name is Dr. Faustin. Currently, I'm here in China, and I am not alone. In the studio here, we have our co-host, which is Dr. Mogata. Just soon we'll see her. She will appear here. And then we have Dr. Victoria, who is here. And we also have our speaker, which is none other than Dr. Augustine Bala. So before we start, I will just go ahead and I will go ahead and open us into a time of prayer, because this is a International Christian Medical Fellowship. So we're just going to start by a word of prayer. And after that, we'll go ahead and do what has to be done tonight. Let us pray. Father God, we thank you for tonight. I thank you for the person joining or listening to us in the other end of the screen. I pray that you will lead the show, that whatever we're going to do, or whatever kind of question we're going to ask, will be for our education, and that your name will be glorified. In Jesus' name we pray, amen. Okay, so I will start by giving you guys an idea how it works here. So we are a group of people. We have people who help within this community, our community of doctors, and mostly medical graduate people. And we are trying to bring Christian medical practitioners, be it a nurse, be it a doctor, be it assistant, whatever you are, as long as you are a medical plus Christian, this is a platform for you. And we will go ahead and have discussion time with our host. But before we go to talk to our host or to introduce our host, I will just introduce our team. So this is our team. As you can see, we have exactly 6 people so far. And as you can see, there is Dr. Augustine Bala, who is the visionary of our platform. And then we have Dr. Eleanor, who's all the way in Ghana, Accra. She's also here with us today in the studio. And then we have Dr. Naomi, who joins us all the way from Jamaica, yes. And then we have Dr. Mogata, who's here with us, who is actually our co-host today. And we have Dr. Victoria, who's also here in China. All right, so I will just go ahead and give a breakdown of our speaker today. I will invite our co-host, Dr. Mogata, who's going to come up and give us the introduction question. So, okay, just one sec. So this gentleman that you see here is our speaker today. We are very happy and very blessed to have him here. And if you do not know him, well, his name is Dr. Augustine Bala, and he's currently in China, where he's doing his residency as a neurosurgeon here in China. And he was born in Liberia, precisely in a town called Kolahun, Lofa. And later he moved in Firestone, where he grew up with his grandparents, plus his mom. Growing up, he actually really looked at other kids having parents who are doctors, engineer, nurse, they have title. And he always wanted something like that. So he told himself, like, you know what? I am going to study. I'm going to become a doctor. So lo and behold, he studied and he was blessed with knowledge and wisdom. And God has allowed him to come here in China back in 2011, where he ended up getting his MBBS degree in 2017 in the University of Hebei. And while he was also studying his MBBS here, he somehow got his master degree into theology, something like that. It's called MAIS. I hope I'm not mispronouncing stuff here. And he went back in 2017 in Liberia, where he cleared his license exam and he was certified as a doctor. And he finally did his dream as he was a kid. Like his dream, his childhood dream, he fulfilled it when he became a licensed doctor back in his country, Liberia. And he wanted to do more, you know, because after you reach a point, you want to go higher. And somehow God blessed him. He got a promotion where they gave him a scholarship of World Federation of Neurosurgeon Society, or WFNS. And he was able to come here back in China, and then currently he's in Jinan University, where he's doing his training as a neurosurgeon. So he's married, all right? He's married, and he has three kids. The first one is 8, Augustine. The second one is 4, Awesome. And the third one is a lady, a little daughter. Her name is Augustina, and she's currently 1. So that's the brief introduction of our speaker today. So I will just go ahead and invite him up so we can all acknowledge him. Hello, Dr. Bala.
Hello, thank you. Thank you for the introduction.
All right. I hope we did say everything about the accomplishment. I know there are more that we talk about. Is there anything else that we didn't say here?
And you said a lot already, I think.
All right. Okay, Dr. Bala, we welcome you in our platform today, and then I will go ahead and ask our co-host, which is Dr. Mogata Flomo, who is also in the studio. I will invite her up. Dr. Mogata, can you hear us? Dr. Mogata, are you there? I think there is a network problem because we are not getting your... Okay, then we will go ahead with the question. So right now, can you hear us, Dr. Mogata?
Am I being heard, please?
Yes, we are hearing you. We are hearing you. All right. The speech is all yours.
So I was saying, thank you so much, Dr. Faustin, and welcome, Dr. Bala. So we will go straight into our questions. I'm expecting today's edition to be powerful. Yeah. So first thing, we'd like to know the definition of stroke and how many types of stroke do we have, Dr. Bala? Do we start with that?
Okay, stroke. So a very simple definition would say that stroke is a common condition that is caused by abnormal brain blood vessels. So the whole thing is around the blood vessels in the brain, and the abnormality of those blood vessels in the brain will definitely determine the type of stroke. So there are 2 major types. Later on, we will talk more about that, but there are 2 major types. So the first one is called ischemic stroke. So even the internists will say a lot about that. And ischemic stroke is that where there is blockage or there is narrowing in the blood vessels that supply blood to the brain, and that will cause damage to the brain tissue. And so when the blood vessels that supply blood to the brain, any or is being blocked, whether by blood clots or debris, and blood doesn't get to the brain, then the damage that start to happen, that stroke, we call it ischemic stroke. So the second step is also the blood vessels that goes to the brain. If it leaks blood or a rupture, then there is bleeding in the brain. So we call that kind of stroke the hemorrhagic stroke. We call that stroke the hemorrhagic stroke. So the hemorrhagic stroke, there are actually two different types under that. Also, one of them, which is actually our focus discussion today, the RCH, what we call the RCH. There's no feedback.
I can hear you, Doc. Just continue, please. There's a little echo.
So, can you still hear me? Can you still hear me? Okay. So the hemorrhagic stroke also have two types. You have the RCH that we call the intracerebral hemorrhage. That is the location of the brain. So we say intracerebral because the bleeding is within the brain tissue. So we call that hemorrhagic stroke intracerebral hemorrhage, whether it's due to rupture or leakage of blood vessels. And then you have the SAH, the subarenal hemorrhage. So actually the brain is in the skull, you have the skull and it has covering. So the layers that cover the brain before getting to the brain tissue, we call them meninges. So you have the first layer, the dura. And so if the bleeding, like in the case of trauma, if the bleeding is above that first layer, the dura, we call that epidural. So below the dura, if bleeding is between those layers, between the dura and the arenal, we call that subdura. And then, but if it is below the arenal, is subarenal hemorrhage. So if the bleeding is between those meninges, between the covering of the brain, that is different when compared to when it is within the brain tissue. So you have that. So the third one, which is kind of tap off the first step of hemorrhage, is called TRA, the transient ischemic attack. So that is also blockage in the blood vessel, but for a very short time. So these are the three types, basically. And just talking about the definition is abnormality in the blood, in the brain blood vessels.
Thank you, Doc. Can you please check your volume? Not really getting you. Sounding very low.
I'm not hearing you. I'm not sure if you're hearing me.
Okay. So let's just continue. Thank you so much for giving us the difference between the type of stroke and the definition. So we want to know, right, as a general practitioner, if you are faced with a patient who has stroke, what should be your first recommendation? And when do we have to consult a neurosurgeon?
Sorry, I didn't really get you clear.
The question is, as a general practitioner, which you are, if you are faced with a patient who has stroke, what should be the first recommendation to that patient? And when do you think the patient should consult a neurosurgeon?
Okay, so I will use the word to kind of just make the discussion very simple. I will say be fast, like B-E and then F-A-S-T, be fast. So what does that mean? As a general practitioner, especially when it comes to the issue of stroke, the first thing you have to be able to have the business skill as a doctor, whether you're not a neurologist or a neurosurgeon, you should be able to have the business skill to be able to diagnose that this patient has a stroke. And you have to be able to take the first, or what we call the initial action, the initial management, and then if the condition is above your level, you'll be able to call for help. So I kind of summarize that for the purpose of this discussion. I say be fast. And so from the history and physical examination, there are a couple of things you should be able to find out that this patient has a stroke, even if you haven't done an evaluation here with CT scan, like advanced evaluation. So the first thing to be, you want to see a patient comes to you with all the history, the presentation, you want to find out, and you're thinking it's stroke, you want to find out for the B, whether there was any sudden loss of balance or coordination. The second thing that I use for the E, the B, the E, the R, is there any sudden loss of vision, whether one eye or two eyes? And then the next one is the F. So the face, is there any abnormality? Like, is there any facial dropping, right? So usually we ask the patient to smile and see whether there is deviation in the face. And then the A, you want to see the arms and the legs, whether there is any weakness or numbness, whether one side or any of the extremities. And then the S, their speech. That's the FAS, the speech. Is there any abnormality in their speech? Are they having trouble to speak? Then the T, time. When did this particular thing started happening to this patient? So the moment you can be able to run through the B fast, you know that even without doing CT scan, you need to know whether this patient has a stroke and whether this stroke is the damage caused in the brain is severe, and you need to take an action to consult a neurosurgeon. So from that B fast, it's giving two messages. One, you'll be able to confirm your diagnosis, this is stroke. And then the second thing, you will be able to know whether you need to consult a neurosurgeon. So I would say you need to be fast as a general practitioner.
Thank you so much. So we want to know, right? So overall, what is incidence of RCH compared to the ischemic tip? I don't know. Can you hear me?
Come again. You kind of a little low.
Can you hear me, please?
Yes.
Did you get the
yes,
question?
I'm hearing you now. Can you come again?
So I'll say thank you. And our last question is, overall, what is incidence of RCH as compared to the ischemic step?
Okay, so actually the ischemic stroke is the most common one, but the RCH or the hemorrhagic stroke is the second most common, but the most deadlier. And so in terms of incident worldwide, let's give global data. Worldwide, I was looking that out. According to the World Stroke Organization report for 2019, worldwide, we have yearly, you have about 12.2 million new stroke every year. 12.2 million people having stroke every year. And apart from that, just 2009 alone, you have 101 person who actually suffer from stroke that have aftermarks just because of stroke. And taking that number into consideration, about 15 to 30% of it was actually RCH. Yeah, you may say, well, that's kind of, second, but the first, the highest number, okay, out of the 100 million, you have 77.2 million of that number were actually ischemic stroke, and then 20.7 million of that is ischemic stroke, hemorrhagic stroke, the RCH. So that means ischemic stroke is more in terms of prevalence or incident compared to RCH, the hemorrhagic stroke, but the hemorrhagic stroke is more deadly. So let me show a picture that I got from the internet to kind of give an idea of what I'm talking about. So if you look at this picture, like I said initially during the time of the definition, the ischemic stroke is due to blood flow being obstructed. And so you have the blood deprived area in the brain here. But when it comes to the hemorrhagic stroke, it's bleeding in the brain. And so either due to rupture from the blood vessel or the blood leak in the brain from this place. And so this is very terrible because you have the blood in the brain here and the damage can be more severe and the patient could die quickly even compared to the ischemic stroke. So this make the ischemic stroke the more deadly one, even though in terms of incident is second most common. And looking at that number also, 89% of that globally, 89% of stroke is believed, according to the report, happens in low and middle income countries. 89% of it happening in middle income countries. Also, 63% happen in people that are less than 70 years. So it's not the issue of old people sickness. Old stroke is old people. 63% in 2019 of that 101 million, 63% happen in people less than 70 years old. So that's the statistic. It's kind of scary though. So I think that's why it's important to talk about it. Yeah, but ischemic stroke is more compared to ICH. But again, I think due to data and if you see 89% happening in low and middle income countries, many of these countries may not even confirm the diagnosis as actually or differentiate from being ischemic or hemorrhagic. So it's possible most of the patients that die from ICH, people may think it's actually ischemic stroke because they never ever did CT scan. Maybe many of the areas there is no CT scan, so they could not even do CT scan to confirm this is actually ischemic stroke or hemorrhagic stroke. And it would just kind of conclude that this is, ischemic stroke. So many times, most of the patients that die from hypertension that the internists are managing, they conclude without CT scan, without even confirming when the patient died, because actually they will do their best medically, but like in the case of ICH, you could do all the medication, all the management, control the hypertension. The patient could still die if the bleeding continue, right? And there was no surgical management. So most of those data that raised the number for ischemic stroke, some of it could actually be ICH, but the facility were not there to confirm with CT from evaluation to really confirm that this is, ICH. So it kind of like increased the data of ischemic, but ICH is very deadly in terms of mortality.
Okay. Can you hear me, Doctor?
Yes.
Can you hear me, Dr. Bala?
Yes, I can hear you.
Hello?
Yes, I can hear you.
Hello? Can you?
You are breaking in, Dr. Faustin, but I can hear you.
All right. So thank you so much for something very important. The ischemic type.
The risk factor. What could be the risk factor in terms of lifestyle or family history?
Okay, so the risk factor.
Presume that is more intracranial hemorrhage. But
there are modifiable risk factors, especially you talk about lifestyle, right? So there are some of the risk factors we can be able to work around. We can be able to do something about it. So I call that modifiable risk factor. And some of the risk factors, we can't do nothing about it. So these are the non-modifiable. So let's look at the modifiable ones, like lifestyle. So one of the risk factors in terms of lifestyle, alcohol, right? So alcohol consumption is a risk factor. That's modifiable. So if you can stop drinking excessive alcohol, you could be able to save yourself. So, but alcohol consumption, chronic alcohol consumption is a risk factor for ICH. And also cigarette smoking is a risk factor for ICH. And drugs, those who take drugs, even some medication. So because certain anticoagulated medication we are on, it can increase your risk for bleeding. So yes, certain medications you are on, apart from it being whether for because of addiction, you have to be careful because certain medication also increase your risk for bleeding in the brain. So yeah, drugs is one of the things. Physical activities. So like for people who work, require them sit in one place for long and sit for hours, they don't exercise, they also have risk factor because you could have a blood clot even from in your legs that could, you know, travel within the blood circulation and get to your, you know, and block the blood vessels and stop blood from going to your brain, and that could increase the tension in the blood vessels, and the blood vessel could leak blood and you could bleed in your brain. So yes, physical activities, right? The kind of physical activities you are involved with is also risk factor. So these are the modifiable ones. What about the non-modifiable risk factors? So age, for example, because you can modify that, right? So people more than 70 years old. So elderly, yes, they are of high risk of that. Even though I did mention in the statistic that 63% of 2019 stroke also did occur in people less than 70 years, but people more than 70 years are even more at risk of having hemorrhagic stroke or bleeding in the brain. And gender, according to statistics, is actually more common in male than female. It's more common in male. So you can modify that, right? And then race, with statistics from the United States, is more common in the Black race. Like from the United States has one of the highest, incident of the prevalence of stroke due to lifestyle, obesity, and a lot of things. But of the stroke patients is more common in the Black race and even more severe. That could be due to the prevalence in high blood pressure, what we call hypertension in the Black race in America, right? So because hypertension is one of the most common factor or the cause for hemorrhagic stroke, or what we call ICH. So in fact, people have to debate that, but the initial name for ICH, intracerebral hemorrhage, was called hypotensive hemorrhage because people believe that that was the cause, but not in all the cases is due to hypertension. So hypertension as a cause is a debatable, it's debatable. So there are many other factors that cause ICH now. So the name has changed from saying hypotensive hemorrhage to intracerebral hemorrhage because other things could also cause that. So let me show you a picture also to kind of contribute to that. I was checking on the internet and then I saw this brain. I was laughing, comparing the normal brain to this, damaged brain. This is the brain of a smoker. That's how you may see the heart. The lungs of a smoker and the normal lungs of a smoker. You compare, yes, it also affects the brain. So this is the normal brain, and this is the brain of a smoker. So looking at that also, we're talking about the risk factor, right? Alcohol. See, the normal brain of a non-alcoholic person and the brain of an alcoholic person is not the same. So is very critical to know. And this, like especially people who taking drugs like marijuana, yes, it damages your brain, and all of those are kind of risk factor for you to bleed in your brain. So then these are things we can actually modify. So I wanted to show that to you.
Okay. All right, Dr. Bala, you can hear me, right?
Yes.
All right, so thank you so much for that feedback. That's a very good one, especially with the picture. It's really clear. But way in the beginning, you mentioned something very important. You say last year, according to the statistics, they have realized that even younger people are getting this, ischemic stroke or even hemorrhagic kind of stroke. So what could be the reason that younger people are getting strokes? Because we know that, as you mentioned here now, hypertension and smoking and all those stuff can cause that. But what can be other reasons that can cause a young person to end up having a stroke? And what could be the age range for that?
Okay, so let me go back again to the etiologies, and I think picture could help us kind of explain that, right? So the whole thing, like from the definition, the whole thing about stroke, it has to do with the blood vessels. So our brain, if you look here, the brain has blood vessels that supply the brain, right? So starting from, let me just give a little bit of anatomy, not to bore you, but I think this will give a picture, right? So the entire brain, like if you see this picture, we call this place the sac of Willis, but then you have the internal carotid arteries, actually starting from the common carotid arteries, going up, it divides into the internal carotid arteries and the external carotid arteries. Have the carotid arteries have even seven different segments up there going to the brain. Then you have the at the terminal end, you have the anterior cerebral arteries, the middle cerebral arteries, you have the anterior communicating arteries, you have the posterior communicating arteries, you have the posterior cerebral arteries, the bacillar arteries going down to the vertebrae arteries. So all these arteries, supplying the brain with blood, any abnormality in any of the arteries will actually lead to problem in the brain. So like if you see this picture, you see a weak area in those arteries could bulge, forming like this balloon, like we call it aneurysm. So apart from hypertension, which is the most common cause, so young people less than 70 years, you couldn't have hypertension, you could have any other abnormalities in your blood vessels in your brain. So in that case, if it rupture, you definitely, have bleeding in your brain, right? So even though you are younger, you couldn't have hypertension, you couldn't be, somebody who's drinking alcohol or smoking, but you could have aneurysm in your brain. If it rupture, you could definitely bleed. You could be as young as 15 years old, and you could be in school just thinking and have headache, and you have a sudden collapse. The blood vessel in your brain has ruptured and there is bleeding there. And so that's one of the factors apart from hypertension. So abnormal blood vessels like aneurysm that I just showed you. Another one is apart from the arteries, we also have veins, because we have the arteries supplying the brain with oxygenated blood. You also have the veins, right, that takes away deoxygenated blood from the brain. And so there are instances where you have abnormality. We call it AVM, arterial venous malformation. So there are people who blood vessel is abnormal. The veins and the artery, if you see here, the veins and the artery form like joined together, and they're not supposed to be together. And so it formed that kind of malformation in their brain. And so this AVM could rupture and also bleed. You could have stroke. So apart from hypertension, you could have aneurysm, you could have this AVM. Even though you are very young, you could still bleed in your brain. Another thing that could be a contributing factor is where young people could have RCH or hemorrhagic stroke. It could be they could have brain tumor. So you could have tumor growing in a part of your brain, right? It could be in the lobe or deep in your brain, whether even in the brain stem, right? You could have brain tumor. And so if the brain tumor is getting larger, it starts to suppress the blood vessels. So that was one of the common symptoms, whether brain tumor, most of the time bleeding in our brain, the RCH, most of the common symptoms would be, we'll talk about the symptoms later, but the common symptom is headache. So once the tumor start to enlarge in your brain and start to press on the blood vessel could leak blood, it could rupture. like you see in this picture. So yes, brain tumor could also cause, ICH. You could blame your brain because you have brain tumor. And of course, that could happen to anybody at any age, right? So these are other factors apart from hypertension. And trauma, on the other hand, you could be involved into, you could be in a car and then get involved in an accident, right? And maybe you could have an aneurysm, you are moving normal, you have your normal life, nothing is happening, but you have an accident, and then the aneurysm rupture in your brain. Definitely you have symptom of stroke, or the AVM rupture, right? Either because of stress or whatever, or trauma could cause that. So these are other factors apart from hypertension, which is more common in older people. So the issue of abnormal blood vessels, like in the brain, like the aneurysm, like the AVM, like brain tumor, they could also cause bleeding in the brain, even in young people.
All right. Okay. So that's a very clear way or detailed way of explaining it. I really like the fact that we even have picture and illustration of understanding what's actually happening. So if you can you please tell us what can be the sign and the symptom? Because you talk about sign and symptom right now. So what can be the sign and symptom to recognize such issue?
So the most common symptoms is headache. But apart from headache, usually like we are focusing more on intracerebral hemorrhage, right? Hemorrhagic stroke, right? And but the most common symptom, whether it's ischemic stroke or hemorrhagic stroke, or what we're referring today to as the intracerebral hemorrhage, yes, headache would be the most common symptoms. Like in ICH, the headache will be smooth but progressive. And then the next thing that happens is you could have nausea and vomiting, because especially if it is like tumor or that is causing compression on the brain tissue. So you have increased pressure in the brain. So the person could start vomiting, they could have nausea and start vomiting. Apart from the headache, they will have headache, nausea, vomiting. Another thing that could happen, which is more common, especially I was talking about the abnormal blood vessels, right? So you could see a 15-year-old person just have a sudden headache and then a collapse. So alteration in consciousness. So if someone have a headache and then just, collapse, that's, you have to think about, what's happening. So these are the symptoms: severe headache, nausea and vomiting, and alteration in consciousness, loss of consciousness. Usually it's happening suddenly. Yes.
Yeah, thank you. So headache. Some of us that always have headache, I think we need to start doing some checkup. So yeah, thank you, Dr. Bada. So our next question, we want to know the evaluation process. So how is it diagnosed, or what tests can be done?
Come again, you are low, Mogara.
Are you getting me now?
Yes, much better.
So I was saying, thank you, and we want to know the evaluation process. So how is it diagnosed, or what tests can be done?
Okay, so for evaluation, and I think I was talking about when we're talking about the data, right? You heard me say from data available, about 89% of these cases is happening in low and middle income countries. For the investigation, you need CT scan to really be able to confirm this is, ischemic stroke or this is hemorrhagic stroke, to confirm your diagnosis. I agree, as clinicians, when you are when you are fast. Like I said, be fast. So once you know your neuro examination, from the history and physical examination, yes, you can be able to say, yes, this is ischemic stroke or this is stroke. But then to be able to confirm your diagnosis, you need to do a CT scan. Because the ischemic stroke and the hemorrhagic stroke, they present with the same symptoms. You could have headache, you could have nausea and vomiting, you could have, a loss of consciousness, right? The same thing could happen in both cases. And so to be able to say, well, this is ischemic stroke or this is hemorrhagic stroke, standard first choice for evaluation is CT scan. And so many facilities in an emergency situation in an ER, many institutions don't just do on a CT scan, they do the plain CT scan and the CT angiogram, because the CT angiogram will be able to show the blood vessels as well to know whether, apart from the bleeding in the brain, whether there is other abnormal blood vessels like maybe aneurysm or AVM. So the CT angiogram will be able to help with that. Even in the advanced situation where, like in China here, in my hospital, in the emergency room, before they call the neurosurgeon, the emergency department doctor would definitely have ordered a CT scan and a CTA. So usually when we go to the emergency room for a consultation to see patients brought in unconscious and thinking a stroke, if they consult us from the Department of Neurosurgery, we are going to see an image already on hand. So you don't call the neurosurgeon in the ER in my hospital when you don't have a CT or CTA. So the moment we come there, apart from evaluating the patient, there should be a CT scan and a CTA, so we can be able to make a decision if this patient needs surgery or not. So yes, for evaluation, the first choice of evaluation in terms of imaging is CT. So CT, and then CTA if it is available. And also in the most convenient environment or better environment, you want to do a DSA, you want to do an angiogram. The angiogram will be much better. It will show clearer picture as to whether there is aneurysm or AVM, like abnormal malformation in the blood vessels. So angiogram will be far better. And if you have the luxury, later on you could do MRI to see, even if it's ischemic stroke, you do an MRI to see whether there is infarction, because it could not be bleeding, it could be damage to the brain tissue due to blockage in the blood vessels, and blood is not reaching to the brain, which is the ischemic stroke. But if you have massive infarction as well in the brain, you can be able to determine whether you're compressed by surgery. So yes, but first line is CT, CTA, and then angiogram, and then MRI if available. But preferably, any institution should at least have a CT scan to be able to go on to say, yeah, this is ischemic stroke or this is, intracerebral hemorrhage.
Thank you. So, CT scan. We need to have CT scan in most of the hospitals. So, is there any time window for the management of such patients?
Yes, time is very important. And when I was talking about, I think when you asked the question about general practitioner, what should you do if you have a stroke patient? When do you consult a neurosurgeon? I said be fast. And the last letter in be fast, like the T there on fast, is time. So time is very, very, very important. In fact, that's one of the reasons why we lost most of our patients, especially the intracerebral hemorrhage patient. The time. So usually something should be done in 3 to 4 hours. Something should be done, especially for hemorrhagic stroke patients. So if someone is bleeding in their brain, action should be to 4 hours, in 3 to 4 hours time. Most of the time, if someone, whether it's due to function or due to rupture aneurysm or due to AVM rupture or trauma, and the person is bleeding in the brain, you have ICH. Usually 24 hours. If the person bleeds for 24 hours before meeting a neurosurgeon intervention, many times the outcome is very, very poor. So you have better outcome if action is taken in 3 to 4 hours. 3 to 4 hours. That sounds very scary for low and middle income countries where you have sometimes getting to the hospital, it takes days. You know, that sounds scary, right? But yes, time is very, 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 very important. And I think that's the reason why the ICH, the hemorrhagic stroke is more deadly, because most of the time before getting to the hospital, if you are in the hard to reach area, the patient will definitely die.
All right. Okay. Thank you so much for that. Can you hear me, right, Dr. Bala?
Yeah. Yeah.
Okay, so this is first of all a call to everybody who's in the chat on Facebook or YouTube. You also can send or write down your question. So when we reach the time for reading the question, we will go ahead and read yours. So feel free to send any type of question related to this topic. We will read it later. All right, so Dr. Bala, as you were speaking, you said something very important. You say that sometimes in your hospital, you will reach the patient, the CT scan is already there. So they will call you. But this means that they might actually not call you, right? Does it mean that every single time they meet a patient with a stroke, do they always have to call a neurosurgeon or a cardiologist or any other specialty can actually take care of that? Or they can just end it with emergency department and that's it? What is the what is
most of the time? Yeah, so most of the time, these kind of actually present in an emergency department. Most of the stroke patients present in an emergency department. So not all of them usually end up in the Department of Neurosurgery. So yes, there are times they are managed in the emergency department, and there are times they are transferred to the neurologist, that's the internist, and they could do medical management. And there are times they end up to the surgeon, the neurosurgeon. So yeah, so asking the question, if the patient lies, what could be indication for surgery? So there are a couple of things definitely will be the reason why the neurosurgeons will be involved. So if the patient is stabilized in the emergency department, most of the time they can say a CT scan is done. A CT scan is done, and at least a CT scan is done. So in the advanced environment, you could have a CT scan, a CTA as well done. And so if a CT scan is done and the lesion has a marked effect, like for example, from the CT scan, use Malan shifts, that the normal Malan in the brain is shifted. That means there is pressure either from the question of the hematoma, from the bleeding. So there is Malan shift, means that compression is severe, and there is edema, there is swelling in the brain, and the image showed that. So with that, and then with the neurological condition, that would be your indication for surgery. That if we can decompress, if we can do surgery, be able to remove and stop the bleeding and remove the blood clot, definitely the Malan will go back to normal, and swelling in the brain will reduce. So when that is the case, many times the neurosurgeon will be able to get involved and do surgery. Another thing I could think, again, apart from just the mass effect, the symptoms. Most of the times, the patient will have hemoparalysis or hemiplegia. That means one side of the body is paralyzed, right? So if the patient have hemiplegia or hemiparalysis, or the patient aphasia that we're talking about, the speech, or the patient is confused, and those symptoms is kind of contributing to increased pressure in the brain. We call it increased intracranial pressure. And also that we think mass effect, like I mentioned initially, the Malan shift, the brain swelling, and the hemiplegia, the speech difficulty, the aphasia, and everything, we think is due to this compression. That surgery, if surgery were to decompress, that these symptoms will be relaxed, then definitely we'll be able to take the patient for surgery. The third thing is the volume of the hemorrhage, the blood in the brain. That's very important. So we're able to calculate that on CT scan. So when we see the volume of the blood, usually 10 ml in between there, that volume of blood where the person maybe semi-conscious, but having all these symptoms, and we see the volume is not more than 30, 10 to 30. Yes, that's large quantity. We definitely want to go and evacuate that blood. So that becomes indication for surgery as well, the volume of the blood. But if this volume is more than 30, because that means maybe this patient has spent like 24 hours bleeding from where they come, and you have like large clot that more than 30 cc or 10 ml from CT scan, and now, well, you have to kind of be critical with that. Now you have to discuss, because if the volume of the blood is very large, and the damage that have been caused probably not going to be reversible, then surgery becomes something we have to think about. Well, we just want to go do surgery when the person will not recover, right? So if it's more than 30 ml, usually we kind of and discuss with the patient relative, because that becomes more like bad prognosis. The patient may not really recover well. From statistic in that case, one patient out of some of the one patient may recover if the blood volume is more than 30 ml. Another one is that if it is massive, like real massive bleeding, that the blood volume is more than 60 ml, and the person GCS is the glycocommon scale. So we evaluate every patient that come, especially in the emergency room. So with our neurological examination, the GCF is also key. We can be able to evaluate the consciousness, right? So the patient opening, the verbal response, and the motor. So if the GCS is less than 8 or 8 below, usually that's we define as coma patient. I mean, this patient is in coma, right? And the volume is 60 ml, and this patient is coma with GCS 8 and below, then surgery also is not an emergency. You want to discuss that and see, because the prognosis will definitely be bad. You can't be setting that, oh, just going for surgery and removing that massive blood clot, then the patient will dramatically recover. No, you can't be, you can say that, because at that time it's bad now, right? And of course, there are people who can even have as massive as 85 ml and above. And if it becomes worse, the location, because the bleeding could occur in any part of the brain, even as deep as in the brain stem, in the midbrain, in the brain stem, right? So the location as well matters. So we evaluate all of that. So, but preferably, especially taking into consideration timing, if the patient gets to the hospital, to the emergency department within 3 to 4 hours. Usually in the setting here that I'm training in China, most of our RCH patients get to the hospital in at least 6 hours. 6 hours. So called ambulance, able to get there in 6 hours. So within that time, the bleeding, the hemorrhage is not more than 30 cc. It's usually between 10 to 30. Most of the patients that we have done surgery for and evacuate the hemorrhage, usually the hemorrhage is between 10 to 30 cc, and they recover very well. The damage kind of be reversible. The paralysis kind of get better. The speech come back and everything. The facial dripping, everything come back usually. But when time is not in favor, where the bleeding becomes really massive, more than 30 ml, 60 ml, 80 ml, even if we do surgery, the prognosis is not very good. So the good window period for surgery is that time where the bleeding is between the volume is 10 to 30 ml, and also where the symptoms kind of can be is something pointing that there is increased intracranial pressure, there is compression, and we can be able to decrease and we can be able to reduce the intracranial pressure. So with that timing, yes, we can make surgical decision very quick.
All right. Dr. Bala, what you say, it's very important, but there is something very that's actually bothering my mind. All that is good, but if a patient is in a remote area, like you say, 6 hours, because within those 6 hours, you will end up doing CT scan, CTA, DCA, and all those tests, right? But if somebody is living in I don't know, somewhere in Africa, or even in China, or even in the state, but in those places, maybe it's more than 6 hours away from the designated hospital. What to do?
Well, the timing from research and stuff, so that's the average. But there are people who could be lucky, I'll put it that way, that, you started having symptoms and even went into coma, maybe in 48 hours and got to the hospital, and you are still lucky. CT scan, it shows that the damage is not really that bad. You could still have bleeding that is that the blood volume is around maybe 30 or less. So that patient could be helped. But again, in response to your question, if a patient is in a remote area without access to CT or MRI, what should we do? So even in that case, there are other medical management, right? There are other initial management that whoever seeing that patient can be able to do before surgery, because there are even instances the person may not need surgery if the of the blood in the brain, for example, is less than 10 cc. Even if you're able to get to the hospital, you stay confused and you're having a headache, we can do medical management. We may not do surgery. We say conservative management. We can, give you other management and keep you in the hospital, give you sufficient rest so that you can be able to recover. So again, I go back to be fast. Be fast. So the first thing you have to do in that case, in the remote area, no CT scan, be fast. I go back over it again. B, you need to check the person balance and coordination, whether there is any sudden change in their balance and coordination, right? They're not able to stand, they can walk again. And the eyes, there sudden loss in vision, whether one eye or two eyes. And then the face, is there face dripping? That's the F. The A, the arms and the legs, is there any paralysis? The S, the C. And then the T, the time. So the moment you check, it's possible BEFAS that those symptoms are much more better. Yeah, so then the timing, you have to, from history, you can be able to know when the symptoms started and how is the person deteriorating, and you can be able to make decision from that. So in that case, if from your BFAST evaluation, if the person GCS, for example, is maybe 14, 13, and those neurological deficits are not bad, the person is neurologically stable, but yes, you think the person has stroke, probably there is still bleeding, but as CT scan, you can be able to say that the bleeding could probably be less than 10 cc from your clinical evaluation as a doctor. And in that case, you want to make sure that that bleeding, the volume of blood in that person here doesn't increase, right? So there are a couple of things you want to do medically. You start in that person. First of all, since hypertension is, I'm talking about high blood pressure, is the most common cause, you want to make sure and evaluate if the person has blood pressure. You control the blood pressure. You give them antihypertensive medication. That's what you could do. You don't need CT scan to do that. Next thing you could do, if the person is in coma, the person, because the bleeding could be maybe in the brainstem and start compressing a functional area there, and the person can't breathe and they can't talk, they're in coma. You should be, if you have that loss rate or the facility, you should be able to intubate the person so that you can be able to help them to breathe from, they have assistant breathing, because if you can't give any assistance in their breathing, they could die before they get to the hospital. So the emergency situation, you want to intubate the person. That could be something you could do as well. The next thing you want to do is that if the person is bleeding, the blood clot in the brain could start compressing functional area in the brain, and that could cause the person to start having seizure. And you don't want them to start having seizure, and that will cause bleeding. So definitely you want to give medication to prevent them from having seizure, or what we call the common people say epilepsy. Yeah, so you want to give anti-seizure medication. You should be able to do that. You also want to make sure that maintain a normal fluid in their body. So it's a vaccable. Research has shown that the best fluid choice for one case of people who have who are bleeding, first of all, is normal saline. You don't want to give them dextro to increase the sugar level already. In that case, the sugar could even increase. So you don't want to give, fluid that have sugar in it, like dextro. You don't want to give other fluid. The best choice of fluid is normal saline. You want to make sure they have they are well hydrated fluid. So you can do this initial management even before getting to an advanced care facility. And most of the time, the person could just be in a state where they don't need surgery. Even if they need surgery, if you can start this initial management in a remote environment, you help them, gain time before they get to the hospital, and you could save life before getting into the surgery.
Thank you so much, Doc. Thank you, Dr. Bala. So we want to know, right? So what is the best surgery or medical management?
So the best surgery or medical management, I think when I was talking about the BFAST right now, I mentioned some of the best medical management, which is the initial one. So if the person is neurologically stable, that means you check your BFAST, you do your neurological examination, GCS, the person is much stable. You can do conservative management. Medical management could be even before you do a CT. If you can confirm from CT that the hemorrhage, the bleeding is less than 10 ml, go for medical management. Put them on rest, give them medication to sedate them so that they don't be struggling, so they don't be violent, so they can relax, so that the bleeding doesn't increase, and the blood clot that could be in the brain could resolve. Could be ordered, as the brain has the ability to do that if it's not, massive. So definitely yes. So the medical management will be more of conservative in that case if the person is in a state where they are neurological and they're not that large. So you can check, make sure you control blood pressure, control seizure, give them medication to relax. Yes, and then maintain normal fluid, and get them in a quiet. Usually, these patients are managed in the ICU. You don't just put in a general ward or anywhere. They need an ICU, much quieter, and then they can improve from that. Surgery. If the bleeding is massive, that is causing all those symptoms like the hemiplegia, hemiparesis, trouble in speech, facial dripping, and all the different symptoms I talk about, then you want to do surgery, especially if the volume of the hemorrhage is more than 10 cc or 20, 30, and you're seeing all the symptoms. GCS, if GCS is even 8 and below, that means, of course, the GCS is just telling you that the person is, not neurologically stable, right? And they continue to deteriorate, you definitely want to do surgery. And then if the decision for surgery is necessary, we usually do what we call craniotomy. Craniotomy, that's just the big word meaning removing the bone. And the position going to depend on the location of the hemorrhage, because like I show you the brain, it could be any of those areas, like where we find tumor. It could be in the loops, in the frontal lobe or the parietal lobe. It could be in the cerebellum. It could be deep here in the brainstem and in the clavus. It could be anywhere. The bleeding could occur anywhere here. And so the position will depends on the location of the bleeding, right? But yeah, we're gonna do a craniotomy that will remove the skull. So normally, before you get to the brain, you have a already hard skull. Yeah. So this is just a prototype I'm showing you here. So usually that means we're going to do a cut thing to be able to skull. So the removal of that skull is what we call craniotomy before we get to the brain. And in most of the cases, depending the location, how deep the bleeding is, you need a microscope. You need an operating microscope to be able to, get out that bleeding. And in some instances, you may not need a microscope. You may need an endoscope to be able to go in. And so if you're using an endoscope, then you don't need a very large, craniotomy. You can just do a small hole, and you can go in with the endoscope and be able to remove the blood clot. In another instance, right now there's an advanced treatment surgical method. We call it interventional neurosurgery. So since it has to do with blood vessel, you may not have to open the skull. You may not have to even do a little hole in the skull to do endoscope or use microscope. You can do, we can use the DSA machine, and we can access the blood vessels from the femoral arteries, and we can go into the brain from the femoral arteries, go to the aorta, and then go through the carotid arteries. So just through the blood vessels from your femoral arteries from the top, we can be able to pull in a catheter and get to the brain and be able to stop that bleeding and do embolization. And yes, like in my hospital, we have that kind of facility. So if it is, for example, aneurysm, we can do embolization. So the patient, we don't have to open the skull. We don't have to do a hole in the brain. We can just do we can put in a catheter from the artery straight to the brain and access the blood vessel and be able to stop that bleeding or remove the clot. And if it is AVM, we can also do embolization depending on the location. But if it is deep in the brain and that interventional neurosurgery may not be your best choice, then we have to do an open skull. So craniotomy becomes the best choice. In that case, you will need an operating microscope, or you will need an endoscope. So in that case, again, thinking about low and middle income countries where you don't have an operating microscope, where you don't have an endoscope, where you don't have a DSA, it becomes terrible. Maybe even if you're a neurosurgeon, you may be sitting there and looking at the patient die, you can do anything. That's sad, but yeah. So surgery, we need those kind of environment. Yeah.
All right. So we see it goes hand in hand with the country's economy, because if the country can afford all that, then that would be better. So we just hope that the knowledge that we are receiving here, that you have received, would be helpful in the country. And especially the last one that you talk about, the one where you put a catheter all the way from the femoral artery to go all the way to the brain. That's a long trip, but that's a very interesting subject. I really like that. All right, so I think we are almost done with our questions, our discussion for today. And now we're going to turn into the chat. Some people have sent their questions. So we're just going to take a few questions because
in the chat room.
Sorry?
I'm seeing some interesting question in the chat room.
Exactly. We'll go through them because we still have like 10 minutes. So first of all, guys, everybody who is in the chat room, you are welcome to send your question. If you just join us now, we are talking about the intracranial hemorrhage and how to treat them and all those stuff. And the speaker is Dr. Bala. So if you are there in the chat, please feel free to send us your question. So I will go with the first question. It says here, somebody texted us, they say, from Facebook, they say, what caused forgetfulness in young people? I don't know if this is based on what we did today, but it goes with the brain. So I think you can answer that.
Okay, that's a good question. Thank you, Diesel, Alice Diesel. Well, sticking to our topic, but definitely we can give you an answer in relation to having a damaged brain, in terms if you have bleeding in your brain, and forgetfulness could be, something that could happen. So the brain has functional area. The reason why, let me start with some of the things that we kind of connect to allow you to understand what I want to say. So the brain has functional area, and there is speech area, there is memory area, there is visual area. So if the bleeding occurred, for example, in the motor area, that's why you see the person will have paralysis. If the bleeding occurred and the damage to the brain tissue is in the speech area, then that's why you see the person will have problem with speech. If the bleeding occurred in the part of the brain that is responsible for memory, and the blood clots start to press and destroy the brain tissue in the memory area of the brain, definitely the person will forget. And so there are people who have stroke, and if the bleeding was, especially hemorrhagic stroke, if the bleeding was in the memory area, it damaged the brain tissues there. Even if they're recovering, they can't remember anything. So in terms of in connection to our discussion today, if a young person have whether a rupture, aneurysm, or AVM, and then it causes bleeding or tumor that press in the part of their brain that are responsible for memory, definitely they will lose their, whether short-term memory or long-term memory, depending on the location. I don't want to go into the anatomic. And I saw one question, somebody said we should make it as simple so everyone can remember, understand. So that I'm saying that the part of the brain responsible for certain function. So if it is the memory area of the brain, definitely the person will forget everything, whether young or old person. So, but generally, forgetfulness in young people, that question is very general. But I'm answering it in connection to the function of the brain. So if you have a damage in your memory, in the part of your brain responsible for memory. So actually, let me tell you, everything we do is controlled by the brain. Yes, your seeing, your strength, your muscle control, your vision, your smell, your taste, everything you do, even your all of your muscles. Everything that you have to do is connected to your brain, whether emotionally, whether anything you can think about, the brain controls that. So if any part of that other part of your brain. You could even become impotent if that part of your brain is is damaged. So yes, forgetfulness could be connected to that. Yeah. Are you hearing me?
Yeah, we can get you, Dr. Faustin. I guess you should be the one reading the questions in the chat room there, please, because my eyes can see it well.
Okay, all right. Dr. Moganta, it's all right. Dr. Bala, you can see the second question, right? So it says
Yes.
here, African sign versus health sign. Which of the two could be responsible for proliferation of madness in Liberia?
Interesting question. African sign versus health issue. Which of the two could be responsible for the proliferation of madness in Liberia? Well, I don't want to give credence to African sign. I'm not a native doctor, and I'm not a traditional soul, so I don't want to give credence to say, well, African sign powerful, whatever. But madness, I'm not a psychiatric, so a neurosurgeon is different. Let me get this clear. A neurosurgeon is different from a psychiatric. So a psychiatric deal with crazy people, and they can be able to tell you all of that. So I studied the brain and the normal function and things that want to damage the brain. I agree. You want to say, but that you're talking about the brain, then you say madness. You don't want to talk about that. Well, there are a lot of health issues. If I started talking about madness, I would start going into the psychiatric aspect. So I would definitely want, in terms of health issue related to madness, I would want a psychiatrist to address that, not a neurosurgeon. Yes, but and I also not want to give credence to African sign. I'm not a traditionalist, so I don't want to make them feel so powerful or feel good, whatever. Yeah, but a psychiatrist would be able to address that. Madness, health issue related to madness, that's more a psychiatrist issue. Yeah.
All right. So thank you so much for that answer. That was a very good one, because sometimes we do confuse between any neurosurgeon and psychiatrist, and say somebody who's working within anybody who's working within the field of the brain. We tend to miss or to confuse them to think that you guys are all doing the same thing. So we are out here staring at you people, staring at the brain. So the same person actually texted and sent another question saying, how do you intend to simplify this program for a non-medical student to understand, such as his grandma or her grandma in Yanuhun? I believe that's a town somewhere in Liberia or somewhere in Africa.
Yeah,
Right?
I think I know where this person is coming from. Well, we're gonna try, but there are just some medical terms that we got to say the medical terms, then we break it down. So you heard me saying hypertension, then I say high blood pressure. So yes, and in fact, let me spit it out. I'm in China, working in what I would say bilingual environment. So I know what simplifying medical terms really mean. So right now, I'm doing my working on a book that's already in the publication. We're doing a simplified medical terminology in English for neurosurgery residency, especially English second language speaker. So what we intend to do, if I'm working on a book in that direction, I will try to bring it as well into my programs here. So the intent is, the medical terms and the everyday term. So for example, I said that hypertension is the most common cause for intracerebral hemorrhage, bleeding in the brain. Intracerebral hemorrhage is bleeding in the brain. Hypertension is high blood pressure. And so definitely, even the grandma in the village, if the grandson sent her a film and she able to watch it on Facebook, she'll know that when she get high blood pressure and she don't take her medicine, it's possible she will bleed in her brain And since she's far away in the village from the hospital, she could die. So that will want grandma to take her high blood pressure medicine regularly. So yes, I think with that, we can't throw out the medical term, but we say the medical term and say the everyday term so that people can understand. I think that's kind of more like explaining. So I said intracerebral hemorrhage. I said hemorrhagic stroke. Then I say bleeding in the brain. I say hypertension. Then I say high blood pressure. So that's the way we try to modify that. And we work on suggestions in other way that we can be able to explain, because the intent of this program is not just to share information among us as medical colleagues, also to help the non-medical listeners to be able to have the information. Because if they are aware and prevention is in place, and the patients know where to go, what to do, that will help, the prognosis or help us be able to do better.
All right. Okay. I think the last question is a bit related to the second one. The person says, is madness related to the brain? So that sounds like the question, the second question.
Yes.
So what do you think about it?
Yes. Madness is related to the brain. I just mentioned that everything we do is related to the brain. The food you eat, like your appetite to want to eat, is related to the brain. To see is related to the brain. To smell is related to the brain. Your emotional desire is related to the brain. Anxiety is related to the brain. So when we're talking about mental health, by the way, it's a whole area by itself, but it's related to the brain. So the brain, so madness, generally answering that question is related to the brain. But then that's why we have so many specialty dealing with the brain, different aspects of the brain, right? So you have behavioral science. Of course, you're talking about the brain. And neurosurgeon, this is the surgeon. This is a guy who can open the brain and do operation. But you have other people who don't do surgery, who don't open the brain, but it definitely has a lot of things to do with the brain, like treatment of the brain and be able to counsel you. Even a psychologist, yes, dealing with the brain, right? The psychiatrists, they have issues to do with the brain. So yeah, madness is related to the brain as well.
All right. Okay, I think we are almost done with our questions here in the chat. I just want to add one more that I received here. It says, how can somebody know that they have aneurysm? Because you say young people, one of the most common cause of stroke is aneurysm. So how can a young person know that they have aneurysm? Is there any kind of checkup where you can annually go and do CT scan in your brain to check if you have aneurysm? Or is it because of family history? Or is it because the person used to smoke, like lifestyle?
So if you're having persistent uncontrolled headache that cannot stop with medication, you definitely want to go and do a CT scan or CT MRI to be able to know what's happening in your brain if you care, right? Yes. So you could be scared. It could be something else. And even brain tumor, right? They're like meningioma, that is the most common brain tumor. A lot of people diagnosed with that, it was just maybe they went to do an evaluation and went to do a brain CT because they were requested to do it for some other reason. Boop! Here's a meningioma in your brain. You've been living with it. You never knew. Yeah, so there are a lot of people that have aneurysm. They don't know, and they're having their normal life. And if they do a CTA, they could just find out, well, I have this. And so if you're having persistent uncontrolled headache and it's not going away with medication, you definitely want to know what's happening to you so you know what to do. Because if you find out you have an aneurysm that is not ruptured yet, you stand a better chance. You will, right now, I hope that my country could be able to get a DSM machine, because I'm getting fascinated. I'm really going for interventional neurosurgery. I hope I can have a DSM machine. I can have a very good ICU that I don't have to open the brain. I can just go through the femoral arteries and then put in my catheter. So I actually got so glued to the professor in interventional neurosurgery. I want to do all the catheter and auto into it. But I hope, because the DSM machine is very expensive. But what am I measuring? That if you find out you have an aneurysm that's now ruptured, is early, you stand a better chance. You can be able to go through interventional, therapeutic means, and then it can be embolized, it can be taken care of, and you don't have to worry that we're going to open your skull and do anything. So the earlier you know, the better for you, right? Compared to you just having this headache and you're passing around, you don't know, and one day you just fall off, and then you are rushed to the ER, poor CT scan is done, you have a massive bleeding, and then it's not, you don't have hypertension, you're very young, it's aneurysm that rupture. Most of the cases I've seen with aneurysm, yes, young people. I saw a case of a 15 years old who fell off at school, and they rushed him to the ER, did a CT scan. So the first thing when we see young people who have, massive bleeding in the brain, have an ICH, we don't think about hypertension, we don't think about high blood pressure. The things we think about is, cerebral vascular diseases. We're thinking about aneurysm, we're thinking about AVM. Yeah, so definitely we think about that. So if you are young and you're having persistent headache, it's not going away with medication, yeah, advise, go to the hospital, be evaluated. If you can do imaging, better. You have nothing, or you have something, you can do something about it.
Okay, thank you so much, Dr. Augustine Bala, for that this show. It was really good. Thank you for accepting to be the one who's going to talk. We really learned something today, and I hope that online somebody has learned something. I see questions keep coming and coming, but because of time's sake, we have to end it here because we are within the time frame. So yes, any word you want to say, anything before we let you go?
Okay, I see someone asked a question there just a moment ago. Let me respond to that. What are the root causes of brain tumor, and how can it be diagnosed? Okay. Well, some of it is something we maybe can say you don't know the cause. Some people it's genetic, and it happens. So how can it be diagnosed? If the person start to have a symptom that we mentioned, one of the cause of intracerebral hemorrhage is brain tumor, right? So if you're having persistent headache, you're having nausea, vomiting, you're having those signs that make you feel that you're having a compression in your brain, you definitely want to go to the hospital to find that. So usually it's diagnosed from the symptoms. You do a CT scan or MRI, and we can be able to know this person has a brain tumor. Yes. So for the root causes, some of it, we don't know the cause. Some of it is genetic. Some of it, we don't know the cause. So I hope I answer your question. And finally, I would just want to say that looking at the statistic, especially those are all from low and middle income countries that have families, or we ourselves suffering from hypertension, definitely you want to make sure that you modify the lifestyle that could put you at risk, like alcohol and smoking and physical activities. We don't exercise in most of our environment we come from. Is good, especially if your job requires you sitting all time. You gotta modify your lifestyle so that you can reduce the risk. And the non-modifiable risk factors, you can't do nothing about that, but you can be on your watch, right? It's good if you know you are hypertensive, you're going to be on your medication regularly. You don't want to have an uncontrolled hypertension that you may bleed in your brain and you don't have the time, because sometimes you may not be as lucky as someone who can survive after having a hemorrhagic stroke for 6, 12 hours or even 24 hours. If you have a stroke and it's hemorrhagic and you You don't have the luxury of time. Even if you have money, you don't have the luxury of time to be flown to the best facility for you to be careful. You could die, definitely die. So if you are hypertensive, you want to make sure you take your medication. If you have a mom or grandmom who is hypertensive, you want to advise them to take their medication and that they don't fall in that, category. Of course, looking at the statistic, we say ischemic stroke is the most common, but because of the facility to not be able to evaluate those cases, there are a lot of people who die from hemorrhagic stroke, the ICH, and we classify them as ischemic stroke because we never did CT, we were never able to evaluate. So I can tell you for sure the statistic from that we have online in places is probably ICH could be higher than that. So I would just want to encourage our listening audience to pay attention to that, pay attention to your health. Not because you are young, you could bleed in your head. So watch up and be careful.
All right. This is something that most people, especially where we're from, they don't like to hear. When they listen, they're like, no. But the thing is, we need to get checked about our blood pressure and then our lifestyle. That's something very good. Thank you so much for that. Thank you so much for your time. I think now we're going to let you go because we will be having our closing statement now. Thank you so much, Dr. Bala, for everything. All right. So thank you, guys. Thank you, everybody, for joining us or whoever is going to watch this video later on. We are glad that you guys were here. And as we said, we talked about intracranial hemorrhage based on hypertension. So I hope somebody has learned something. I hope I learned something. So I hope that we all learned something. So this is the time where we give our announcement, or shall I say closing statement. So if you want to contact us or you want to contact anybody within our community, our email is here. As you can see in the screen, our Facebook page is also there, and also our Instagram and WhatsApp group. It's right there. You can go ahead and scan it, and you can get in contact with us for whatsoever reason. And we also have some sponsors and people who are partnering with us. We are glad that this is a community that we really want it to grow. So go ahead and spread the message. Go ahead and talk to people about this, about Christian doctors who want to get together and talk about health stuff. All right, so I think we can go ahead and close our meeting with a time of prayer. Father God, we thank you for tonight again. We thank you for Dr. Augustin Bala, for his family, for his work. We pray that you will allow him to grow in more wisdom like Solomon. And I pray for whoever joined here today, that you're going to talk to them, that you're going to learn, that we will learn more from what we heard today. Help us if we have any lifestyle that we need to modify. God, help us to modify them so we can be healthy. In Jesus' name we pray. Amen and amen. All right. Thank you guys for coming. Don't forget to subscribe and also to share and like and comment however you want. Thank you so much.